This meeting is being recorded.
Okay, so this is OMT 101, Part 2. In this Part 2, we are going to review video clips of all 9 techniques in our continuum as a review of Part 1, just so that you can visually see some of these techniques being done properly. We will, of course, be practicing these in our OMT workshops in the OMT clinic and in your personal clinic patients, but I wanted to review these with you visually. So we're going to start with soft tissue OMT, and then we'll go to counter strain or ISTM, and then counter strain, myofascial release, facilitated positional release, still technique, muscle energy, articulatory, and then HVLA. We'll give you an example of that. So we're going to start here with a paralumbar soft tissue technique demonstration.
Sias of the pelvis on the ipsilateral side. So I'm just going to be grabbing this bone right here in the front of your pelvis, okay? All right, so now making contact with the ASIS. And then at the same time that you're applying an anterior and lateral pressure with your cephalad hand, you're also going to pull your ASIS posterior, which is going to provide a counter leverage force. And you can do this either as a intermittent, more rhythmic stretching and kneading, or if you have a particular area that is more restricted, like this upper lumbar region right here, you can apply a more sustained pressure. And you'll wait just until you feel tissue release. And when you begin to feel some tissue release, then you can continue with the rest of your treatment, treating any areas that have any particular restriction. And then we'll return our patient back to a neutral position and then reassess for somatic dysfunction. And that does feel significantly better on that right side.
Okay, so that was a good demonstration of paralumbar soft tissue, and we will do many, many soft tissue techniques over the course of your curriculum. All right, so we're going to move on now to another technique, and I think what we will do is the ISTM next. This is the instrument-assisted soft tissue myofascial release technique, and I will get it to a point here where I want you to observe it as a demonstration. Things that I want you to see in this demonstration include the instrumentation of the myofascial and soft tissues to the point of petechiae. And then you'll see this practitioner stop at that point and not take the patient completely to bruising. So it might only take 5 or 10 strokes with the blade. It may take more. The blades that I particularly like to use are the boomerang blade. It's so named because it's shaped like a boomerang. These are surgical stainless steel blades. They need to be sterilized with some either alcohol wipes or Santa Claus wipes in between patients. I also use an S-shaped blade, such as this one, which I'm trying to, there we go. The S-shaped blade. I rarely use any other blades. There are many blades on the market. Whatever you feel comfortable with, you will learn to feel and palpate through these blades, and it will increase your palpatory skills for myofascial trigger bands, trigger points, bogginess, ropiness, any type of tissue texture change. You can palpate through these blades much more effectively than you can even with the pads of your hands. So we're going to observe this now, and this is a very important technique for you to use and take with you If it is the only technique you take with you into clinical practice, I promise it will give your patients a lot of symptom relief and do them a lot of good in their journey to whole health.
Deeper layers without abrading the skin. All right, maybe I used a little bit too much lotion. I tend to use a little too much lotion, maybe more often than not. I guess it's better too much than too little. You guys will see if you use too little lotion, it like feels like a rug burn real fast. All right, so we'll get that all in there. All right, good stuff. All right, now we're going to start with our scanning strokes, but before I do that, I want to lengthen out this cervical fascia. Then I'm going to go ahead and just gently take the tool, 30-degree angle, push it into where I feel muscle kick back, and then just do nice little organized strokes so that as I'm going through each little strip of skin, I can take note on where I felt dysfunction, and I feel a little bit up in here, and a little bit right here.
What you're going to see here is that he's using the blade, like I said, for his diagnostics. He's literally feeling that myofascial tissue through the blade. When he says he's scanning, that's what he's talking about. And he'll identify some restrictions, some trigger banding, and then he's going to target some treatments here so you can see him actually treat those once he's done doing his diagnostic scanning with the blade. The diagnostics is, 30-degree angle, very soft fanning, but you still see that you're going to get some redness and erythema even with the scanning.
Think of those binding of those tissue. Maybe I'll start up here at the top of the neck. And I'm just gonna, in this way, I'm gonna almost treat this one like I treated the trigger point in the previous one because I have such a small surface area to go after. It's gonna be hard for me to get various directions. Maybe I can get a little bit this way. But I'm probably just as well grabbing the tip of this shark fin tool and trying to break things up that way. Remember, I'm going to go in multiple directions because fascia, the collagen fibers, don't necessarily match the muscles underneath them. All right, you guys can see I got a little bit of petechiae right there. All right, so then I went, this area was next. All right, so I can go in this direction, right, towards her neck. And then maybe I go at a diagonal towards the front of her neck, diagonal towards the back of her neck. I can go maybe across this way and back. Just breaking up as much as I possibly can in as many directions as I can. I don't know if you can see, if you lean back just a little bit. There you go. You guys can see I developed a little bit of petechiae. Once again, I don't think there's anything therapeutic about the petechiae, but I do think it's a good indication that maybe we should stop. And you can see I only did about 15 strokes there. We get past petechiae, we start getting bruising. All right, so the next spot we're going to do, let me have you lean forward just a little bit of that. There you go. Is this spot here, which we felt a little disruption. And now I'm just using this concave side, and I'm just doing my little sweeping strokes, I guess you'd call them. You know, I do think way too much attention is paid to the name of strokes and the fanciness of strokes. You're really just trying to get a 20 to 45 degree angle and pull tissue across other tissue. You're trying to create shearing forces. So as long as you're going in multiple directions, I think we're going to be as congruent with what the research is indicating as we can at this point. Now, the next thing I might want to do is go after trigger points. And now it's funny because the common trigger point sites we already went after. That's where we felt the most abrasive or the most abnormal tissue anyway. So I'm not going to go back over this, but you guys can imagine I just use the end of this shark fin tool and go around in a circle like so. right? Really trying to break up that tissue.
You can really see how he's getting the petechiae and the erythemic reaction there. Um, and at the end of the treatment, you'll see that he has really, really mobilized that myofascial and soft tissue. It's extremely effective.
Fit the trap mount real good. So maybe I come down over like this, and then we kind of had some different levels of intensity. We had pin and passive pull through. We had pin and active pull through with overpressure. And then we had pin opposing pull through with the tool and active pull through with overpressure, right?
Okay, so that is IASTM. And we will be doing that quite a bit in our modules, in our sequences, and at the bedside. Okay, so the next technique that I'm going to show you is counterstrain. Counterstrain is a tried and true osteopathic treatment, and we're going to show you some counterstrain of the lumbars, anterior lumbars. These charts are in your curriculum module manual, so you know where to look for these counterstrain points. Get this video to the point where I want it here. Okay, so we're going to start this video right. He's found a tender point on the left side, left anterior lumbar tender point. And then we're going to listen in and watch him treat this. He's going to wrap that tender point. He's going to wrap the body around it until he gets that tender point down to a pain level of 0, 1, 2. The patient will give her input as far as what position that is. And you'll see him modifying the position of her body around that tender point. But basically, you're going to flex that the body parts around that tender point. In general, that's what you're going to do. Sometimes you will move a body part away, and it's going to be better for the patient. It's always directed toward the end point is always directed by the patient's comfort and decreased pain at that tender point. But in general, you will find that flexing all the body parts around that tender point is where the magic is, and getting that tender point to the point of treatment.
To bring our leg up on top of the table, bend their knees up, and then rest their lower leg on our knee. For AL1, we're going to stand on the same side as the tender point. And we're going to rotate the pelvis towards that tender point. So the point is on the left. We're going to rotate the pelvis to the left by drawing the knees towards us. We're also going to side bend towards, so side bend to the left, by bringing the ankles closer to us. Now, this motion of rotation of the pelvis to the left and side bending to the left also rotates the torso relatively to the right, which shortens the muscles that are contracted in this instance. So now that we've achieved the treatment position, we're going to compare to our original pain scale. So compared to the original 10, what is the tenderness now?
It's a
2. So from here, we can fine tune with a little bit of additional flexion and rotation, some side bending, and what is it now?
A 0.
0. So now we would maintain this treatment position for a total of 90 seconds, or until we feel some kind of tissue release that indicates that the tender point has dissipated. And of course, after that 90 seconds, we would return our patient to a neutral position passively. So we're going to assume that we completed our 90 seconds, and then we would return our patient back to neutral, scoop our patient's knees, and then rest them down, and then we would reassess without lifting our finger off the point. Now, if we were going to instead treat
Okay, so perfect demonstration of strain counter strain. Now, 90 seconds doesn't seem like a long time until you're holding body parts in that position for 90 seconds. So that's kind of what limits strain counter strain in a primary care setting somewhat. Now, if you have a few tender points that you're treating, that's fine. It's very effective, especially for people who can't tolerate any more aggressive direct treatments. However, that's where the myofascial release, facilitated positional release, and then the still technique continuum was born out of that. So we're going to look at a good old-fashioned myofascial release technique, and then we'll move on to the FPR and still technique. I'm going to show you a myofascial release of the thoracic inlet, and then I'm going to show you a suboccipital myofascial release technique. Both of these are deeply embedded in our sequential OMT treatment protocols that we're going to be learning. So we're going to start with the thoracic inlet, which is the horizontal diaphragm at the upper thorax. I'll get that to the point where I want you to see him actually doing this technique. He's figuring out here where the thorax is, or the thoracic inlet is diagnostically. So he's checking all the planes. I want to get you to the point here where he's actually treating it. Okay. Here we
Look are in an anterior point of view, posterior. We can also go lateral on the right, medial on the left, lateral on the left, medial on the right, or we can go medial on both sides, lateral on both sides. And for my patient, what I'm finding in this area is my greatest point of restriction is anterior, and then lateral on the right and medial on the right. Now, in terms of how I'm approaching those restrictive barriers, it's important to note that I'm not just kind of gliding along the skin. I'm not just kind of shifting my fingers all over the place. Instead, what I'm trying to do is I'm trying to shift my focus and my vector of force kind of pointing in whatever direction that, that restricted barrier might be. So again, I'm setting up with an anterior direction and then lateral on the right, medial on the left. And then I'm going to hold that for up to 2 minutes, but I'm looking for any evidence of tissue texture change that indicates tissue release, improved circulation, or decrease in tension. And I'm already beginning to feel that and feeling decrease in tension under my fingers. So I'd follow that decrease in tension. As an enhancing maneuver, I could also utilize respiratory assist and have my patient take deep breaths in and out. So when my patient takes a big breath in, go ahead. I'll feel increased tension under my fingers and I can resist that. And then with exhalation, I can follow as the fascia relaxes more. And that would be more of an enhancing maneuver that would improve my tissue release as I'm reaching any restricted barriers. And once I've felt sufficient tissue release, then I would return the tissues back to neutral, and then I could also reassess. And from there, I could also continue in different areas of the thoracic inlet.
Hello.
You have decided to treat this with a soft tissue inhibition technique. Your patient will be supine on the treatment table. Your patient should be comfortable. They may need to bend their knees. You will sit in a chair or stool at the patient's head. You should be comfortable with your feet flat on the floor. First, find your landmarks. These will be inion and the occipital protuberances. While maintaining contact with the occipital bone, slide your finger pads slightly inferior to the occipital protuberances along the base of the occiput. Ask your patient to relax their head into your hands. Create a fulcrum by extending your fingers anteriorly into the suboccipital space. Gravity will provide the force necessary to bring the head into your palms as the tissue softens. What you feel soften initially is likely semispinalis capitis. The location of your fingers is affecting the myotendinous junction of the suboccipital musculature. As the head falls further into your palms, the next layer of muscles that releases are likely the suboccipital triangle muscles. This may take anywhere from 30 seconds to several minutes, depending on the patient's tolerance and severity of their hypertonicity. As with all soft tissue techniques, this can be repeated 3 to 5 times to achieve relaxation of deeper muscle layers, or if the patient is having a difficult time relaxing and allowing gravity to take control of their head.
In this video, we're going to discuss and demonstrate counterstrain for the
Okay, so two very good examples of the myofascial release techniques. And again, our curriculum is and our modules are full of these myofascial techniques. So very important as we move along here that we focus on these very important initial modalities of soft tissue, IASTM, counterstrain, myofascial release. And then the next one that we're going to demonstrate here is facilitated positional release, which is the next one in our treatment continuum. And essentially, facilitated positional release adds a vector force, a compressive force. I don't like the distractive force. I prefer a compressive force. I find it much more tolerable to the patients, and I also find it clinically to give me better outcomes. So we will watch a facilitated positional release demonstration here of the cervical spine. And then right after that, I'm going to show you the still technique, which is facilitated positional release, including the compressive force. And then you take that around a range of motion, an active range of motion, engaging that restrictive barrier. So you start out very indirect with facilitated positional release, and then you kind of take it through a direct. It's kind of a combination, and it's a very effective technique, especially on the cervical spine. But I'm going to show you the still technique on the first rib, which if you're struggling to get the myofascial release on the thoracic inlet and you treat that first rib, it's very effective. So we're going to do the FPR of the cervical spine, and then the next video that you're going to see in the demo is the still technique for the first rib.
This is FPR technique for the cervical spine. So first off, we want to screen the cervical spine for any dysfunction. And for our patient, we have a diagnosis of C3 flexed, rotated, and side bent to the right. So the first step in FPR is to bring the spine to neutral. So I'm going to contact both transverse processes with one hand. So I'm getting on both transverse processes of C3. And then I'm going to remove that normal lordotic curve of the cervical spine. So now it's in a neutral position. And from this point, the next step is to either add compression, distraction, or torsion to the point where the tissues feel very relaxed. So I'm going to add compression down to C3. And about right here, the tissues are relaxed. And the final step is to bring C3 into its position of ease. So now I'm going to bring her into a flexed, rotated, and side bent right position. And then I would bring her back to neutral and reassess.
This is Still's technique for a right rib 1 inhalation dysfunction. We'll start by putting our left hand to monitor rib 1. With our other hand, we're going to contact the olecranon. We're going to bring the arm up into the fully abduct and flex position. I'm going to induce a force along the humerus directed at that first rib. And once I've done that, I'll feel a softening at rib 1. I'll then move the elbow across the midline and down to the side, all throughout maintaining that force directed at rib 1. And then reassess. Take a deep breath in.
All right, excellent. So we've got a still technique on the first rib. The next thing that we are going to observe here now in our continuum of our treatment stacking is the muscle energy, the articulatory technique, and then ultimately the high velocity, low amplitude technique. And you will notice that we have all of these continual techniques here that you can use to try to treat the somatic dysfunction and get release of it before you get to any of these more direct techniques. So that's why when you're approaching these treatment strategies, you always start with the higher yield soft tissue myofascial techniques in preparation for and often resolution of the somatic dysfunction before you ever get to the more direct techniques. Okay, so the next thing on our list is going to be a demonstration of muscle energy, which is an isometric osteopathic technique. And this one that I'm going to demonstrate is, or have them demonstrate, is a myofascial or a muscle issue, often presenting to family practice offices when someone is bending over doing yard work and stands up too quickly while lifting something out of the trunk of their car. And when they stand up, they get excruciating pain deep in their pelvis. And oftentimes they're unable to stand up straight because the iliopsoas is the major flexor of the hip. And when contracted, it will bend you forward even when you're walking. So you will encounter this quite often. And this muscle energy technique is one of the most effective muscle energy techniques that you will have in your tool belt. So we're going to watch that. And I'm going to follow that by an articulatory technique of the cervical spine called the figure of 8. To set this video up, I want to tell you that before you do any articulatory muscle energy or HVLA techniques, spend your time preparing the myofascial tissues with the soft tissue, ISTM, myofascial release, deep tissue massage, and get the area prepared for these more direct treatments. So you just don't jump right into an articulatory technique of the cervical spine without preparing the tissues. All right, so we're going to start with the muscle energy of the psoas, and then we will show you the cervical spine figure of 8.
In this video, we're going to discuss and demonstrate muscle energy for the psoas muscle. But instead of focusing, and we're going to begin by flexing the knee here. With one hand, we're going to support the distal femur proximal to the knee, and then with our other hand, we'll place that on the sacrum to try to stabilize the sacrum and pelvis. Now here, we will bring the hip into extension as we try to appreciate the tension of the psoas muscle. Once we feel like we've reached a restrictive barrier relative to the psoas muscle tension, then we can have our patient press their knee down to the floor. So go ahead and push your knee down to the floor. And we're going to provide an isometric resistance, sustain that for 3 to 5 seconds, and then go ahead and relax. Our patient's going to relax. We're going to relax momentarily while maintaining our position, and then we will stretch the psoas further into the next restrictive barrier. Once we feel that restrictive barrier, then we'll repeat the cycle. Go ahead and press down to the floor. and then relax. They relax, we relax. Move to the next restricted barrier. Go ahead and push down. And relax. And we'd repeat this for a total of 3 to 5 times. At the very end, optionally, we can add a passive stretch to the psoas, then return our patient to neutral, and then we would reassess for tension of the psoas muscle. The bottom of the cervical spine, using our index and middle fingers to find, going to cradle their head, and we're going to be using our index and middle fingers to find their articular pillars. And we can start either at the top of the cervical spine or the bottom of the cervical spine. And then there are 2 options for how we can proceed here. We can either apply a little bit of compression using our abdomen on the top of their head, and in a neutral position add a little bit of longitudinal pressure just to add a tiny bit of compression to the cervical spine. Or we can add some traction with our hands cradling the head. We can lean back slightly to add a little bit of traction to the cervical spine. So I'm going to demonstrate the compression version first. So first, we can add a little bit of compression using our abdomen, and we can find the articular pillars. And here we're now going to move the cervical spine through all of its ranges of motion using a figure 8 pattern. So we're going to add side bending and rotation, and shift the cervical spine with a little bit of flexion, extension, side bending, rotation, and use our fingers pivoting on the articular pillars to encourage motion through the restricted barrier wherever we feel it. So we're using this to evaluate and as well to treat any areas where we feel resistance. So here I'm feeling a little resistance as I'm moving up to C3, so I'm going to do this a couple times, and as I start to feel improved motion, then I can move up to the next segment, again maintaining my cradle and maintaining my contact with the articular pillars. And I can move up and down the cervical spine as needed, and then bring my patient back to neutral position and reassess for any improvement. If I want to
Okay, so there you have the articulatory technique for the cervical spine and the muscle energy technique for the psoas. And again, focus on your sequence there and prepare those areas before you do myofascially, before you do those more direct techniques. Okay, so that brings us to the HVLA. This particular HVLA demonstration is going to be, he's going to be targeting a posterior rib angle. However, this is the same technique called the Kirksville double arm technique. It's a staple HVLA technique, in my opinion, for family practice. So we will work a lot on this in the workshops and in the OMT clinic so that you feel confident doing this technique safely. It targets mostly the thoracic spine and ribs. So the setup is a little different. For a thoracic spine, you keep your hand more over the transverse process, and as opposed to the rib angle. But here he's going to demonstrate more laterally over a rib angle when he does the thrusting. So let's go ahead and watch the HVLA of the costal rib angle here.
rib is going to help pull that inferior aspect of their arms. Very similar to thoracic HVLA, we're going to go far over near to move the scapula out of the way as much as possible. Now we're going to have our patient roll towards us, or we're going to roll our patient over, and then with our hand position, instead of putting our thenar eminence at the transverse process, we're going to move lateral to the rib angle. And on my patient, I had previously diagnosed her with rib 3 inhalation dysfunction. So I'm going to find T3 and then move lateral to find that rib angle. And then I'm going to put my thenar eminence on the superior aspect of that rib angle. So what that's going to allow me to do is when I roll my patient over onto that hand, onto my thenar eminence, and I apply my thrust is going to be in a force vector that's up towards that rib. But because my thenar eminence is on the superior aspect of that rib, that thenar eminence is then going to generate a kind of opposite force that is going to be downwards, which is going to allow that rib to move downwards into exhalation, which is the barrier of motion. So again, on the superior aspect of the rib angle, then rolling over with their elbows in my epigastrum. And now you can also fine tune with a little bit of cradling. So go ahead and lift your head a little bit. And you can fine tune your restricted barrier. All right. And then once you have your direction of force, you have your patient take a deep breath in. Go ahead, deep breath in and out. And with each breath, you want to increase your restricted barrier. Again and out. Now let's do it one more time. And at the end of their exhalation, I'm going to thrust downwards and upwards. Okay.
Okay, so there's a good demonstration of the thoracic double arm HVLA. So in viewing these techniques and having them demonstrated, I believe that the purpose of doing OMT is to relieve somatic dysfunction. So you have to focus on what skill set you want to develop, which modalities you want to develop, so that you are able to address the somatic dysfunctions that you find, whether they are viscerosomatic, whether they are primarily acute somatic injuries, so that you can perform OMT and help people in family practice settings. So when we teach this, we want you to focus on this continuum and understand that all of these techniques are equally effective, and all of them are based upon good myofascial palpatory skills to locate those somatic dysfunctions based on your TART findings. So a little bit about the contraindications and precautions when it comes to OMT. General precautions, you want to informed consent, just like any procedure. OMT is a procedure. So obtain informed consent, avoid HVLA in patients with severe osteoporosis, severe thoracic kyphosis, fractures, history of multiple fractures, malignancy, infection, neurological deficit. Exercise caution with cranial OMT in patients with elevated intracranial pressure or intracranial bleeding by history. Pregnancy, some techniques are high risk, are contraindicated in high risk OB patients early on in the first trimester. We will avoid those techniques in our protocols, and we will make sure to point out which of those techniques you want to avoid at those in those specific cases. Advanced degenerative joint disease and severe pain, OMT is often limited with severe joint osteoarthritis and degradation, frozen shoulders. Oftentimes, these require further, more invasive interventions, including injecting the joint spaces, which we will also do in clinic if OMT has been rolled out as an appropriate first step modality. Bleeding disorders, anticoagulation medications. Evaluate each patient's comorbidities and modify your treatment plans accordingly. All of these treatment plans, including our sequential OMT modules, they have to be filtered through the specific patient and their specific needs. Red flag screenings are the same for OMT clinic as they are anywhere else in family practice. New bowel or bladder dysfunction, incontinence, progressive neurological deficits, severe weakness, fever with back pain, trauma, weight loss without explanation, history of cancer, new onset spine pain, nocturnal bone pain. All of these should be second nature to you as physicians. Summary and key takeaways. The core principles here are treat the whole person, not just the symptom. And osteopathic manipulation is another tool in your belt as a family practitioner. Use palpation, TART findings to diagnose somatic dysfunction. Practice that palpation on every patient that you see, and it will soon develop into a key skill. Move from gentle to more direct techniques as your tissues permit, and always reassess and adapt your approach and your treatment and how aggressive you are to your patient's response. Clinical sequencing, always address the diaphragms and transitional zones, the cranial diaphragm, thoracic inlet, the respiratory diaphragm, and then the pelvic diaphragm. We believe that increasing venous and lymphatic return through those diaphragms by decreasing somatic dysfunction and restriction of those diaphragms matter. So start distally and work proximally to the region of complaint. You'll see me demonstrate this over and over. Do not just jump right into the area of complaint. Treat the area and transitional zones above and below, and then address the area of the major somatic dysfunction. End with lymphatic techniques and patient education. Part of this whole health treatment planning requires us to eventually educate the patient on corrective rehab measures they can do at home, foam rolling, home stretches, TheraBand exercise programs for home, and also, training up maybe a significant other or family member to help with some of the soft tissue and myofascial things that they can do to help these people when they flare up at home. Always screen for your red flags and be purposeful in your patient selection. Not all patients are good candidates based on mind, body, and spirit. Okay, so my last little snippet here is keep OMT simple. Learn to trust your hands, diagnose what you palpate, and treat what you find. Focus on the fundamental goals of restoring autonomic balance, optimizing venous and lymphatic flow, and improving range of motion. These are the outcomes that we're after. Everything else is refinement. So this concludes the OMT 101. If you have not done so, please watch the OMT basics videos on the website that deal with palpation and diagnostics and language of somatic dysfunction and diagnosing in osteopathy. And we will proceed with these training videos. The next one will start our modular sequential OMT videos. One by one, we'll go through the sequence of the treatments, and we will demonstrate what that treatment would look like at the bedside.